is Sarah Field doing a case presentation on a 14-year-old male presenting with his mother to his primary care provider. He has a known diagnosis of von Willebrand disease, and the following presentation leads to the diagnosis of infectious mononucleosis. So JW presents with his mother as a 14-year-old male and complains of a fever, malaise, and sore throat that started approximately 8 days ago. JW states that his throat hurts really bad, feels raw, and rates the pain as a 7 out of 10. He also reports a occasional mild headaches, band-like in nature, achiness. He describes the pain as achiness and rates it as a 4 out of 10. JW's mother reports that he had a fever of 101.5 degrees Fahrenheit last night, and that he last took Tylenol last night for the fever. And also states that he has not seemed like himself and has demonstrated an overall decreased energy level as well as a decreased appetite. JW's mother, as well as JW, deny any close friends or family having any recent illnesses. So, JW has a known diagnosis of von Willebrand disease and has experienced frequent epistaxis throughout childhood as well as easily bruising. Von Willebrand disease is the most common congenital bleeding disorder affecting about 1% of the population and is caused by a deficiency in either the quality or quantity of von Willebrand factor, which is an adhesive protein that helps platelet aggregation in order to form clot at the site of endothelial injury. And also, von Willebrand factor stimulates the mechanism of factor VIII in the coagulation cascade, which also leads to clotting. Von Willebrand disease is inherited usually as an autosomal dominant trait, and there are different types of the disease that characterize the severity of the deficiency of von Willebrand factor that exists for the patient and can lead management of the disease or management of an acute bleeding episode. These patients are not usually on long-term medications. Usually it's treated by desmopressin at the time of an acute bleeding episode. These patients can be pre-treated prophylactically before any dental surgeries or other surgeries to prevent an increase in bleeding. So, social history. JW lives with his parents in Aurora with his mother, father, and 2 younger brothers. His parents are married, have associate degrees, and both work full-time outside of the home. JW attends high school in Aurora 5 days a week and states that he really enjoys his subjects of math and science. Pertinent family history. Von Willebrand disease is often diagnosed by family history and any bleeding complications after surgeries. So JW did also have a circumcision as a newborn and experienced a complication of bleeding after this and was hospitalized for approximately 6 days. His father has a known diagnosed von Willebrand disease type 1. So, review of systems was mostly done in the HPI. Additionally, JW denied any difficulty sleeping, chills, night sweats, recent weight loss or gain, any eye or ear infections or pain. He denied any increase in bleeding or swelling of his gums or epistaxis, but does occasionally 1 to 2 days a week have this happen at baseline. He denied any abdominal pain, any blood in his urine, stool, nausea, vomiting, or diarrhea. He reported arthralgia in bilateral knees and ankles over the last 3 to 4 days. No confusion, dizziness, or syncope, and any increase in bruising. No rashes, petechiae, or overlying skin changes. He reports really enjoying school and hanging out with his friends after school, playing outside or watching movies. Vital signs. Temperature at the time of visit was 102 degrees Fahrenheit, heart rate 75, blood pressure 105/70, pulse ox 98% on room air, respiratory rate of 16. He is 4'11 and 85 pounds. So on a physical exam, JW appears lethargic, is ANO times 4, appropriately interactive, well-groomed, able to move on and off the exam table independently. His pupils are equal, round, and reactive, sclera white, normal nose examination, clear and free of discharge, no erythema on nasal turbinates. Oropharynx was erythematous with bilateral enlarged tonsils, +2 in size, and white exudate noted bilaterally. No petechiae or lesions were noticed, and normal dentition was noted. Bilateral tympanic membranes were pearly gray with both having a light reflex intact. His neck exam, he did have anterior and posterior cervical as well as submandibular lymphadenopathy noted on exam. Lung sounds were clear. S1 and S2 were noted. Abdominal exam, he had a normal GI exam. I was specifically looking for splenomegaly or hepatomegaly, which were not noted on exam, and there was no pain to light or deep palpation. GU exam was not performed. Musculoskeletal exam was not performed in detail, but a normal gait and coordination was observed. Bilateral knee and ankles were examined with no edema, warmth, or erythema noted, as well as no pain to palpation. JW did not have any skin rashes, no jaundice. His skin tone was normal for his ethnicity. So, as mentioned, the diagnosis from this case was infectious mononucleosis by Epstein-Barr virus. Diagnostics for this would be the monospot test, or also known as the heterophil antibody test, which was positive. Also, it would be important to test for rapid strep A test. In this case, it was negative, but due to his pharyngitis symptoms, however, it was negative. A CBC and LFTs should also be sent. CBC specifically to check for lymphocyte count, which would be elevated for infectious mononucleosis, and also to check for anemia and thrombocytopenia. Thrombocytopenia can be caused by infectious mononucleosis, which would put this patient at further risk of bleeding on top of his already known von Willebrand disease, which puts him at a higher risk of bleeding. So, management for this patient. Tylenol, continued PRN Tylenol for fever and headaches and throat pain. No NSAIDs, no ibuprofen or NSAIDs due to the increased risk of bleeding associated with the use of these medications. The patient should stay home from school to rest, drink lots of fluids, follow up for another visit with his provider in 3 weeks, or if fever persists longer than 1 week or becomes higher than 140 degrees. 911 should be called if there is any acute sign of bleeding, blood in his urine or stool, significant bruising after injury, or nosebleed that is not stopped by manual pressure. Learning points from this case are that because mononucleosis can cause spleen enlargement, avoiding spleen rupture for this patient is essential, and even more so because of his von Willebrand disease. Due to the risks of thrombocytopenia and anemia, his infectious mononucleosis on top of von Willebrand disease puts him at an even higher increased risk of bleeding. So it should really be discouraged that this patient do any activities that will put him at risk for injury. Mono can further decrease von Willebrand factor present in the patient's body, which also increases his risk for bleeding and puts him in a more severe state of von Willebrand disease. And NSAIDs are not recommended, as I mentioned earlier. And that is it. Thank you for watching.